everybody. Welcome to another session about pregnancy. The commonest thing, which everybody is scared of in the beginning part of pregnancy is bleeding in pregnancy. So even when you go to your, you're being told, and when you go to your doctor in the OPD and things like that, the first thing, when the doctor explains when to come to the hospital, I'm very sure she'll be telling you that if you have severe pain abdomen or if you have bleeding, please come over, we'll have a check, right? So the commonest event at all stages in pregnancy, or the thing which everybody is worried about, is bleeding. Okay, so now okay, you're bleeding. From where are you bleeding? The next question is, from where do you bleed? Okay, most of the times it's from the mother. That means you are bleeding, not the baby. It's not from the baby's side. So that's quite a relief. But usually it's the mother who bleeds. So it's never fetal. Fetus is not the source of the bleeding. It's very, very rare that, very rare conditions that baby can bleed through, and that doesn't generally come in the early part of the pregnancy. So why do you bleed in the early pregnancy? That means within the 12 weeks or 16 weeks. Why do you bleed? See, at that point of time, very early on, between 6 to 8 weeks of gestation, the decidual plate is forming. That's where the blood is being infused into that area, and then you may see bleeding because of the disturbance or disruption in that level. So you may see 1-2 drops seeping out, or you can get a little more bleeding. If the bleeding is very heavy, then we try to treat you keep you in the hospital to observe hemodynamically. If you're unstable, we keep you in the hospital to observe. So what are the sources of bleeding? So okay, I told you it's mostly from the mother's. Then from where can it start bleeding? So usually when it coincides with your next period, that means you missed your period and that you were supposed to get your period today or around that time, and you see some spotting bleeding around that area, we attribute it mostly to implantation bleeding. That means the fetus is trying to fix itself inside the endometrium, and 1-2 drops of bleeding is common at that point of time. So that is what we call it as implantation bleeding. The next thing can be threatened abortion, or we may be signs of miscarriage. The other thing is miscarriage itself, or an early pregnancy loss, and sometimes it's ectopic pregnancy. There can be lesions on the cervix, there can be lesions on the inside the uterus, or there can be vaginal lesions or lacerations. So I told you what is implantation bleeding. The next thing is threatened abortion. That means when the baby is trying to fix itself, or when the pregnancy is not going smooth. It can be because of many reasons. There could be a septum inside the uterus, or the luteal phase is not proper. There's not a good amount of progesterone supporting the baby. You may have a little bleeding, or it is trying to get out. The pregnancy is trying to come out, or that is called as threatened abortion. So it can be that can also be treated, right? Then miscarriage or early pregnancy loss. So I've seen this very commonly between 10 to 12 weeks of gestation. 7 weeks, beautiful, heart rate is all good. The doctor says everything is fine. Then you go home, and suddenly after 2 weeks, or probably after a week, you just come back with a little bleeding or spotting. And then when we go for an ultrasound, we find that there is no heartbeat for the baby. That's a miscarriage, and we find it very frequently between 10 to 12 weeks. So almost, some 10-20% of the patients we do find it out like that. And the next thing is the ectopic pregnancy. This is what everybody is worried about, even though its percentage is very minimal, about 2%. Sometimes the pregnancy is not situated in the right place. That means it's not inside the uterus. It can be present in the tube, which is adjacent to the uterus, or it can be sometimes in the ovary. So many places for ectopic pregnancy. So in case of ectopic pregnancies, again, you may bleed. Painless bleeding can be there, or very painful, and then still you may be bleeding. So since the pregnancy is situated somewhere else, the decidua starts leaking. You may start bleeding when you come for an ultrasound. We may not find the fetus inside the uterus. We'll find it in the tube or somewhere outside the uterus, place where it is supposed to be. So ectopic pregnancy is one of the reasons for it. Then cervical lesions. For example, polyps. The commonest are cervical polyps, means growth, benign growths on the cervix. So when we have this cervical polyps, generally we try, until and unless it's bleeding, we generally try to reassure you that things are okay or what to do for it. We'll let you know. Then if vaginal, if there is any laceration or there is any kind of a lesion in the vagina, then we'll address it, we'll tell you what it is. Then uterine pathology, like there can be fibroids, there can be septums, that means uterus can be two parts, or there can be bicornuate uterus, two different parts of the uterus, and one horn the pregnancy is sitting, the other horn may be bleeding. So there can be multiple pathologies that will be found out only by ultrasound. So many of them are worried when we say we need an ultrasound, but ultrasound is the best way to diagnose what is the reason for it. Alright, okay. So this is the other part is threatened abortion, I had told you before. So the commonest things, these are the reasons for having bleeding in the early part of pregnancy. So most of the times it settles on its own. That is expectant management. We do not do any special treatments for all these things until and unless we find a pathology. Otherwise, we generally try to do an expectant management. That means we do not try to interfere. But if it's an IVF pregnancy or an artificial pregnancy, like artificial reproductive techniques were used, like IVF, generally we try to give the luteal phase support. That means we try to give some progesterones to keep the baby safe, because it takes at least after 12 weeks is when the placenta is settling and the placenta supports the fetus. Till that time we may support the pregnancy. And how to go about it. So you started bleeding in the early part, even though we have discussed all this in the OPD, sometimes you may have bleeding. So how to go about it? First thing is reach out to the hospital. You need to go to the hospital. You messaging your doctor or calling your hospital about bleeding is not going to help you. Until and unless the doctor has specifically given you some instructions, kindly reach out to the hospital. So she will suggest an ultrasound first. Once you've gone through an ultrasound, or an internal examination also will be done, the ultrasound and the internal examination to rule out the causes. If there is any kind of, I told you, the polyps, cervical polyps, vaginal polyps, any lacerations, means tears with the vagina, all these things will be addressed and taken care of. Suppose we have a suspicion of pregnancy, and here I would like to add one thing. If you had gone through a health check before pregnancy, like a pap smear, it is very helpful. So sometimes the cervix looks very congested during pregnancy, so it may be difficult for us to ascertain, if you have an ectropion, or if you had a lesion on the cervix. If it was there prior and somebody has recorded it, somebody has seen it, a pap smear was done, and all the cancerous conditions are ruled out, it will be very useful for the present scenario. So always it's better to get a prior health check before you go for your planning a pregnancy, especially pap smear and going through your rubella test. All these things is very essential. The preconceptional counseling part, when you go and meet your doctor, please make sure you get an ultrasound, you get a perspiculum exam and to see the cervix, get a pap smear done, breast examination or the breast scans, and regular blood work. So this will really help us to tackle this situation of bleeding better. Now, if we have a suspicion of, we did a scan, we are not able to find a pregnancy inside as well as the outside, but your pregnancy test is showing positive, then we ask you to do something called as beta HCG, that is the blood test. So the beta HCGs, we will be asking you to do it placed 48 hours at the same time. So the first sample for today and the second sample after 48 hours, so that's called the doubling time. Suppose it was 100 at one point, it should be 200 after 48 hours. So we look for the doubling times. So when are we able to find? So some of them are very anxious, doctor, please get the scan done. So at least I need 1,500 to 2,000 if I have to do a beta HCG, if I have to do an intravaginal scan to find out where the pregnancy is situated. Suppose I have to do it on the abdomen, at least we need to have more than 4,000, roughly 6,000-ish beta HCG for us to find the sac through the abdominal scan. That means from the top. When we do the scan from below, minimum 1,500 to 2,500 should be the range. So what are then, suppose let's assume that we found ectopic pregnancy. So then, yeah, the doctor will suggest what to do, whether this pregnancy is gone really further where I cannot do a medical management, or we have to go about the medical management. So medical management is nothing but giving you methotrexate. That is a medication which we also use during cancers. So, but not have to be worried. These dosages are minimal. It all depends on your body weight, and there is a criteria to do the medical management that the doctor will explain and go about. But if the doctor thinks that doesn't fit into the medical management bill, then she will be probably going for the surgical management. Then what are the contraindications for medical management? Sometimes we don't do the medical management if there is a problem with the patient medically. For example, renal insufficiency, there is some problem with kidney disease the patient has. Patient is on immunosuppressive drugs or immunodeficiency, active pulmonary tuberculosis, or she's breastfeeding. We generally try to avoid methotrexate. Breastfeeding patients, we ask them to stop breastfeeding for at least 3 to 4 days or probably a week, and then we give the methotrexate. We ask them to go ahead with it. And the ectopic pregnancy sometimes can be cervical also. That means cervix is the opening of the uterus, or the mouth of the uterus we call it as. So the pregnancy can be situated into the cervix, and then it starts growing there. Then you will see a lot of bleeding on and off, on and off. When we try searching inside the uterus, there is no pregnancy, but there will be sitting inside the cervix, right? Even though cervix is a part of the uterus, but it is not a healthy pregnancy. It is not a correct place for the pregnancy to be situated. The scar pregnancies, these are something which is very unique. It's a part of ectopic pregnancy, especially if you had a previous cesarean section. Then there is something, you have a scar on the uterus. The inner layer, the inner scar, is where the pregnancy gets attached to, unfortunately, and starts digging into that scar. So this again is not a viable pregnancy, and then it's not in the right place. So because the scar is always low down in the uterus, the pregnancy is always situated on the upper part of the uterus. So when it is situated inside the scar, and it starts eating up the scar, and it's again called as an ectopic pregnancy. So then here again, when we come to the next part, so we've ruled out ectopic pregnancy, and then when we do a scan, they talk about subchorionic hemorrhage. So if there is a baby inside, and then there is a good heartbeat, and then you find minimal bleeding there. We always compare it to the sac size. What is the size of the fetus? What is the size of the sac in which the fetus is situated? And then how much is the bleeding? Depending on it, they'll give you the minimal subchorionic, moderate, or severe subchorionic hemorrhage. So how much you're bleeding. So that means that there is bleeding inside. So no matter what, if the heart rates are good, we try to manage you conservatively, and expectant management is what we call. Doctors sometimes prescribe progesterone, sometimes give medications to stop the bleeding or clot the blood over there. So it all depends on what the doctor sees fit for you. So especially, as I said, if there is an IVF pregnancy, we try to increase the progesterone doses or give a lot of luteal phase support for the patient, or the support till the baby is about 12 weeks. If the heartbeat is good and the doctor says things are okay, then I don't think you need to be really worried about it. And sometimes without your knowledge, you would have got your period also a little late, probably a few days after, and then you suddenly again start bleeding, and then when you check, you come to the doctor, and then we check, and it is positive pregnancy, but you would have miscarried, and a little bit of part or something is remaining inside the uterus. That is called the retained products of conception. So that you may again have a problem. It has to keep pushing out, right? Okay. So that you may have bleeding at that point of time, and depending on the severity of bleeding, the doctor decides what is the best way to treat you. Sometimes you have twins, and one of the twins' heart rate stops. That's called the vanishing twin. Again, because that twin has stopped and that side it's trying to get out, you may see some bleeding. So that's called the vanishing twin. That is also a possibility, and you may have bleeding during the early phase of pregnancy. And missed abortion, then as I discussed earlier on, so roughly between 10 to 12 weeks, the baby's heart, sometimes there is no heartbeat, sometimes the baby comes up even at 6 weeks and gives a heartbeat which is very feeble, and then at 7 weeks it just the heart rate disappears. Again, uterus gives us the sign that you'll start bleeding, and then that is a miscarriage. So this is also one of the reason for the bleeding. So is it scary if you have a lot of bleeding in the first trimester? What does that you expect for the future? So we know that sometimes this extensive subchorionic hemorrhages can cause preterm labors, a little FGR, smaller size babies, but otherwise generally nothing. Suppose you are negative blood group, please inform your doctor that your blood group is negative when you have the bleeding, because as such we may be giving you an injection to protect, because we do not, and husband is positive blood group and we do not know what is the fetus's blood group at that point of time. We generally give an injection to protect the fetus from the positive negative effects. So you should remember to always inform the doctor if at all you are negative blood group and the husband is positive blood group. And then what is, suppose they did a study of about 550 pregnant women. In that 117 of them had bleeding. That's almost 21% had bleeding prior to 20 weeks of pregnancy. So that is the bleeding, the percentage of bleeding. So almost 20% of the women will bleed during that point of time. In that, how many miscarried? About 67. In 117, about 67 people miscarried. That's roughly about 12%. So sometimes we cannot stop the miscarriage process because there can be small defects in the fetus and things, so it can come out. If there is any treatable causes, probably the doctor will look into it. Otherwise, sometimes there are some causes which cannot be treated, so we allow the expectant management to take place. So hope you understood about the bleeding in pregnancy, and have a wonderful afternoon. Thank you so much.